Okay. So, yeah, so 66-year-old male came with NST and QMI to hospital and with severe LV dysfunction. When he presented for the first time to us, his EF was 30%. And see, he had old antival MI and post bypass, that is in 2005. And subsequently, once he underwent CAG, which showed triple vessel disease and some disease in SVG to D1, and SVG to RCA was occluded long back, and RCA was CTO, which is filling from collaterals from LAD and LCX. LAD, it is filling from Lima to LAD as well as SVG to LAD, which are filling RCA. So in that sitting, we did basically, to tide over the crisis, we had to do a procedure. Next slide. So these are the comorbids, and this is the angiogram you can see. So LAD is total occlusion, native vessel, and LCX is a small territory, but otherwise it's fine. Next slide. And you can see again, this is a native coronaries, which are LAD total occlusion. Next slide. So this is a right coronary artery. So you can see a chronic total occlusion of right coronary artery. Next slide. So you can see this is Lima to LAD, which is filling nicely, the distal LAD. So you can also see some sort of filling in right coronary artery into the PDA. In Lima to LAD injections. Next slide. So this is the SVG. You can see there is a tight lesion in SVG to diagonal. So this is the index presentation of the patient. You can see even LV contractility is quite poor. And you can also witness, tachycardia, which is a patient was in tachycardia and a little bit of decompensation. So, and this is the reason, for his acute deterioration. So tight lesion in SVZ to diagonal. And next slide. And in fact, what is happening is RCA is also filling predominantly from LAD. I think that also contributed to the decompensation of patient. So since his LV is very poor and patient was not really affordable for mechanical circulatory support, so our plan was just to tide over the crisis and to bring the patient out of decompensation. So we did a stunting to diagonal. So you can see this is post-stunting result. So, and it's predominantly done because patient also had mild renal issue. So we didn't want to give much contrast. So we did a IVUS guided stunting to the distal diagonal as well as ostial diagonal. So, and you can see before and after procedure. Next slide. And in follow-up, patients' LV function improved significantly. So from severe LV came to kind of mild to moderate LV. Next slide. Yeah. And then we planned right coronary artery CTO. You can see this is RCA CTO. This is the index angiogram at the time of non-QMI. So it's a long segment CTO. And there is a kind of ambiguity in the cap. You can see there are two branches coming out of proximal cap. So there is an ambiguity in the proximal cap. And if you see the retrograde filling is only there up to the crux in a left injection. So it's a long CTO from proximal RCA up to the crux. And yes, there is some calcium sitting. The next slide. In the middle, and there is also angulation. And you can see this is Lima to LAD, which is also filling PDA. So basically, the distal RCA circulation is filling from native LCX as well as LAD septals, and which are filling from Lima as well as SVZ to diagonal. Next slide. So this is the anatomy, we can understand, mid RCA CTO. So, and there is also LAD CTO. And this is SVZ to diagonal, in which there are two strands, which we did in index scenario. And this is a Lima 2 distal LAD, so which is filling LAD. And the good interventional collaterals are septal collaterals, you can see, which are connecting to PDA. But these septal collaterals are originating, beyond LAD CTO. So that is the concern. And coming to JCTO score, it is very high. So ambiguous cap and long length and angulation more than 45 degrees. And there is also calcium, and it's also, it's okay. It's a first attempt of RCA CTO. So nearly a 4 JCTO score. So that says, it's a very complicated CTO. Next. So our wiring strategy for this case is, since the cap is ambiguous and the length of lesion is long and CTO is present up to the distal bifurcation, so even with antegrade wiring, so it is very difficult to reach retrograde lumen. And even if you try to reach, sometimes you may lose, one of the branch. So it is, you can do an antegrade preparation first, followed by go retrograde, or directly come retrograde first, and then you start doing antegrade preparation. Either way, it can be done. But since for retrograde septal collateral is coming beyond LAD CTO, so we decided to go ahead, retrograde preparation first, so that, I can come down antegradely, quite easily, because we have to save even time based on how, my retrograde preparation goes. So it's a primary retrograde, which is planned, followed by, antegrade preparation, and then based on the progress, we can decide connecting spaces. Next. So I think these are the challenges which already, I discussed, and then we can move on to live inbox.
Comments from Dr. Vijay. I just have a few concerns. This with the kind of case like this, patient who's post bypass.
So
with a patent Lima, you've opened the diagonal, and the circumflex is also not too bad. I don't know what do we gain a lot by opening this RCA CTO. Number one, because this RCA might have been occluded since long back, and the patient was doing fine. He presented with an ACS, which was clearly due to the diagonal, and his EF also has improved after doing the diagonal. But of course, these things are more medical than technical. Coming to technical, I would just like to say that the antegrade success in a procedure like this is almost less than 20-30%, I think. And the retrograde options are very limited. The only good retrograde option could be from the circumflex to PLV, but we couldn't see good connections. And also, of course, they're epicardial. And going retrograde from the LAD is very difficult unless we open the LAD CTO first, because we also have to consider ischemia if you go through the Lima to the LAD2. So that is probably a very difficult route. So first, we probably in one procedure, we try to open the LAD, but then we'll have competitive flow in the Lima, which has been doing well for such a long time. So, so these are my thoughts. So if I am there, I will not do this RCA CTO, considering the overall anatomy of the patient. Dr. Vijay, we should have your comments, please.
Yeah, it's a valid comments, Dr. Himanshu. And maybe I think, what do you think about this distal LCX? Sharath has done POBA to that. I don't know, maybe a vessel was very small, or like a reasonable sized OM branch. What do you think about it? Maybe if it is stentable, first stent that. And a small concern is LAD doesn't appear to be very great, right? It is a very small, tiny LAD giving 1 or 2 septals, and it is not extending up to the apex. And if he has an apical part of the LV that is viable, and the PDA territory, if it is viable, maybe if you demonstrate good amount of ischemia and viable territory in that part, particularly when you have borderline LV function, it may be beneficial, provided that, again, your concern is valid here. And this type of cases should be done by a very experienced operator. That is the question here. For a routine person, as you said, it is first thing is medical treatment, because it is reasonably improved after the first procedure. And maybe now we have exceptional medical treatment, maybe we can just try that sometime. But an experienced CTO operator, and if it is very confident of opening that RCA, maybe a PDA is a big brand, looks like it's a reasonably big branch. And considering that LAD is stopping midway between mid LV and to the apex, maybe it is a reasonable option to open this RCA and expect there is some more improvement in LV function. And if you see the first procedure, I think it's used a long sheath for this procedure. I'm not very sure whether the patient had some PVD, tortuosity, or what happened in that. And maybe again, fortunately, they could escape without using a hemodynamic support in the first instance. And another thing is competitive flow between LAD and diagonals. So that is also looks like there is some competitive flow. But the good thing is still both LAD and diagonal are open. Maybe if feasible, doing one more stent, if feasible, if the vessel size is good, stenting to OM, then based on your experience level, attempting this RCA CTO.
Totally agree. I think whenever somebody sees this kind of procedure, we should think about the patient safety. We have a patent lemma, we have a good circumflex, we have a graft to the diagonal which is open. Now, if we want to open this RCA, first of all, I need to be safe for the patient. If the lemma is doing well, don't open the LAD CTO because you want to open the RCA CTO. That is dictum number one. Lemma is the lifeline of a patient, so never make competitive flow to lemma in any situation unless the lemma is atretic. So if the lemma is good, never try to open a LAD CTO to open the RCA CTO, because that is not something that is probably advisable. Here, coming to technical part, of course, this is a technical forum, so it is a forum for investment procedure. So this procedure is shouting out investment from the outset. We know it is not going to succeed antegrade, and there are very few retrograde options, and that is why it is being presented in this webinar. But of course, then you need to have experience in investment also. So that is what we should learn. So I think we can go to the case and see how Dr. Sharath and his very nice team were able to do this procedure.
Thank you. Thank you, Manshu and Vijay, for nice comments. And most important thing is, say one thing which is very important is safety of the procedure. And that is paramount in such patients, without considering all safety points, it's very difficult to, really take these patients in cath lab. For Vijay's comment on LCX, so LCX, there was a lesion, but the vessel was too small. And there is an epicardial collateral which is filling your big RCA territory. RCA territory is huge for this patient. Huge one.
Considering this LAD is a very small one, looks like it is type 2 LAD or something. So then again, there comes the importance of opening PDA if it is feasible.
Yeah. So that's the reason, see, if I open and put a stent there, and if I occlude that epicardial collateral to PL, so probably, I may cause more damage, by saving a small branch, I'm occluding a collateral to the big branch or big territory. So, and that's the reason, we didn't want to do anything to that small vessel. We just left it. Yeah. And as Himanshu mentioned, so Himanshu suggested we shouldn't open LAD when the lemma is patent, but that's what exactly I did. Sorry, Himanshu. So I'm confessing before and moving on to live inbox. So our plan is, see, in this patient, septal collateral is the safest interventional collateral than epicardial collateral. So that's why we preferred septal collateral. And the patient had an SVG to distal RCA, but that is totally occluded. That is totally occluded almost more than 7 years. So had it is less than 1 year, probably I would have, gone through that SVG. But it is almost more than 7 years. And also important thing is that CTO is extending beyond the SVG distal anastomosis up to the crux. So that is also another reason why SVG, doesn't work for this patient. So, and SVG is not a great collateral for this patient. Otherwise, yes, that is the safest than sample collateral. So, having said that, I think we'll move on to the live in box. So, already, this is almost 2 hours after all editing. So, I'll try to squeeze it down.
Explained.
So
About the case, it is a post-CABG scenario with an RCA CTO.
So what we are doing is primarily, we started with LAD.
So that's the reason we took 2 microcatheters.
As I already mentioned, I want to just go through this. Right. So you can see, there is one microcatheter in through SVG into diagonal, that is retrograde. There is another microcatheter from that is Corsair into LAD, native LAD. Okay. So, basically we want to reduce the contrast injection. That's why we went with 2 microcatheters. Diagonal microcatheter is to visualize distal vessel, and this one is to wire. Okay. So you can see this is a dual injection with microcatheters.
Okay, so, all right. So we're trying
and then I did an antigrade wire escalation. So I'm trying to skip some steps. So you can see this is Gaia 2. So antigrade wire escalation we did. And in 2 views, like areocranial and elevocranial. So we directed wire Gaia 2. But what happened is Gaia 2 actually was, it went just subintimal, mainly at the distal cap. So I can show you, I think, so you can see this is one injection. So it just going beyond the distal cap. So what I understood, basically the distal cap is also hard in this patient. Because it is, filling from SVG. So it is hard, and it looks there is some calcium. That is the reason the wire is going in subintimally at the distal cap. So I tried repeatedly with Gaia 2. You can see here in elevocranial. So the wire is looking towards left, and we tried correcting in Alevo, Arevo.
Towards LAD, and I'll recheck in Arevo. So the position is correct. Yes. Yeah. No need.
So in Alevo, Arevo, we tried directing, this wire, but unfortunately, you can see the guide support. See, when I'm trying to push wire, literally I'm pushing wire with that 3D assessment, but the guide is coming out. So yeah, that's what happened. So eventually, Gaia 2, you can see here how the guide is coming out when I'm pushing wire. So yeah. So, and at some point, actually, everything came out. You can see here. So we're trying to see, we are at the distal cap, but subintimal. So yeah, I understood it is mostly because this wire is not able to perforate the distal cap. That's why it is moving into subintimal. So you can see when I'm pushing the wire, guide is popping out. That says the tissue resistance is too much there. So, and we decided to escalate to, harnett. So that's my next escalation generally. So I think, this is where
you can tell the audience how harnett is different from Conquest Pro 12, except the gram force.
Yeah, so it's basically both are taper tip, and basically to put it in one word, both are almost similar. But harnett has a taper tip, I think almost 0.09. It tapers to 0.09. So that is a advantage Yeah, and I'm used to Harnet. That's why I generally escalate to Harnet. But
Let's check.
if operator is comfortable to Conquest, you can go to Conquest 12 or 20.
Sharath, Hornet is also not pre-shaped, right? You have to shape it yourself, right?
Yes. We have to shape
Let's go to
ourselves.
electronium.
Why didn't you consider a parallel wire when it was going subintimal? Just keep that Gaia 2 there and take another wire. It would have improved your support also.
Yes. So if you look at, I think this is Harnet. So if you see, the wire is going subintimal because it is not able to perforate our the C cap. And if you have observed, when I'm pushing Gaia,
the guide is coming out.
And pushing, the guide is coming out. So I need a taper tip and high tip load wire which can penetrate.
No, that is fine. I'm just saying that if the wire is going subintimal, just let the wire be there in the subintimal space, the first wire, and then take another microcatheter. Take this microcatheter out and take Hornet on the second microcatheter.
Yes, we can take a W.
The backup will increase. Yeah, the backup will increase.
Yes. See that is one strategy. See, of course, that is one strategy. What one problem is to apply that strategy? Yes, there is a CTO, and the vessel is also diffusely diseased, proximal to the CTO. So, and I'm not sure, whether the double lumen would have gone deeper so that, I can escalate wire from proximal cap. So that was the only concern, I had. I think, yeah, okay. So I think this is Harnet. Yeah, you can see this is Harnet,
It's going into the same track.
Yeah. So that, that's what Dr. Himanshu has told, generally parallel wire is better because otherwise this wire also go into the same track. And that's what happened in the beginning. But the only you can see now, Himanshu.
Yeah, it's free now.
Just, that is what I was trying with the Gaia. So I know where I have to go. Yeah, I know where I have to go, but the problem is wire is not able to penetrate.
Yeah, it's more septal side. It was going more diagonal side. The other wire. Yeah.
And that's how two views, two orthogonal views is very, very important in, wiring. So now we are just, you can see now.
But
this through lumen, and it reached even before diagonal. I don't want to kind of re-enter. So then we lose diagonal. So in both the views, it is in the true lumen, and you can see how big RCA territory is.
Just light and see. Yeah, I can just see the wire is going.
So this is slide test which I'm doing. So we'll just.
Hornet could penetrate the distal cap. No, the challenge is, we have to create a space here. Okay. Distance is stopped there. Don't go beyond. No.
So we are trying to advance microcatheter because.
Microcatheter.
But that was not going. So
I can't go.
Distal cap.
Small balloon will go,
Yeah,
I can see here the wire was actually going around the disc.
So it's all review of what we spoke. And then what I did is we dilated initially with 1.25 balloon and then with the 2 balloon to create a space. And after 1.5 balloon, we exchanged wire. Now you can see this is a 1 horse wire.
Outside 150 with the wire.
Yeah. So, and
we don't need this. Come out. Go to yellow, please.
We removed diagonal chord side. We
to avoid triple injection, so we are basically using sequential, double injection. Yeah, now I think this I'll use for RCA.
So you can see
this
Himanshu, same guide. Now I'm switching into RCA.
But JR for RCA.
I think, see, it may not give great support here. So, but see, I mean, if you have techniques to enhance your support, it's fine.
Okay. Okay, so you did not stent the LED. You are just trying to go through the septal into the right.
Yeah.
We are taking
Yes.
for septal crossing.
But I created a good enough space with a 2 millimeter balloon, and I think I also dilate only 2 millimeter balloon. So, and we crossed the septal with CO03.
So
this is CO03.
Yeah,
but it is safe in this case because there is a good flow from the lima. You could see competitive flow in the distal LED.
So you can see quickly we crossed. This didn't take much time. It's only crossing LAD CTO that took some time. So this has not taken much time. So we crossed.
Okay. I think
and beyond the crux, there is the CTO.
Yes.
So, okay,
and you can also see the wire buckling there at the crux.
Yeah.
Okay. So now we tried advancing, Corsair, but it took a lot of effort to advance the Corsair. And
is it the normal Corsair or Pro XS?
XS.
Yeah.
It's XS. But at some point of time, catheter, it has a catheter fatigue.
Yeah.
So I had to take out and take another. See, what I'm doing here is I'm just enhancing support by sending CO03 into PL. Advanced CO03 into PLVB so that it gives enough support to advance, Corsair. So that's what we tried, and but despite that, it didn't work out. So then I had to switch to another microcatheter, another Corsair, and with that we crossed.
Because support provided by CO03 is quite weak actually most of the time. So.
So yeah, we crossed here. So now the Corsair is almost at the crux. So and now I am switching my wire to Fielder XTR because I just want to try and track some microchannel if it is present.
Okay, so I think this septal is basically joining, at the junction of PD and PLVB. So,
Dr. Vijay, what would you like to say about this strategy up till now?
Yeah, I think Sharath, as he said, he felt a septal is the safest way to go through. And it looks like an extremely difficult case, right? It's one more CTO and a long segment proximally. We'll just go see that how it goes. So that's why it has become an investment procedure.
I honestly believe whenever it is almost like treating two difficult CTOs in one session.
One set,
yeah. So, beyond the catheter fatigue, the human mind fatigue, the team fatigue, the patient fatigue also comes in actually. I'm sure really after first 1.5 hours in the same case, you may do 10 small cases that you never get fatigue. But you do one long 4-hour case, it is actually the last 2 hours, you are only worried that no thrombus should go, nothing should happen to the patient, no air should go, is he bleeding, what is the pressure? So it becomes difficult. That is why it turned out to be an investment procedure. But with skills like this, it will be not an investment procedure if it was one CTO in a day.
Yes. Yes, I think, you're absolutely right, Himanshu. So, and these are the kind of cases where, obviously, at least in my experience or, whatever work I'm doing, I always keep investment procedure in mind, while entering case. Because obviously the time is going to be the limitation in such patients and operator fatigue, with the time, everybody will be fatigued.
And radiation, you are seeing milligray, 2000 milligray, 1500 milligray, your mind starts clicking.
Yeah. So, fine. So, one point I want to emphasize here is when there is an SVG which is connected to distal RCA, it is a very tough game to bring, retrograde wire into mid RCA, because the course of SVG, course of distal RCA appears almost the same in LAO. So I think this is the third case where I faltered. Initially I thought of I was in RCA, but I was not in RCA. It just went into SVG. This is one point. Yeah.
Also be mindful of a venous graft to RCA. Come to RO, please. Let's have a look at the course of the wire.
So I was mindful of that, from beginning, but
the venous graft will come to the anterior, narrower view, whereas.
So that's a point. So in RAO, venous graft comes, will be anterior generally to the
it's not going into venous graft. Go to LO, please.
But this is not anterior in RAO, right? Here it doesn't look anterior in RAO.
We are still in distal RCA, Himanshu. Only when it comes to mid RCA, then you will start realizing where it is.
Okay.
Yeah. Okay.
I think despite
give me Gladius.
This is field Rex here. So finally,
just come to RAO. So this is where we should be careful. We should make sure.
And here you have to come to RAO and see.
Okay. Yeah, SVG will basically go to anterior.
I felt it is in RCA,
like
but
please. Give me Gladius, please.
but the wire is not progressing. So
okay, I think now it's time. So right, okay, yeah.
Sharath, when this XT is not progressing, do you try knuckle wire with this, or you just escalate to Gladius and do a knuckle?
Oh, first I always, in this case, Vijay, so you should know where you are first.
Yeah.
So if there is no venous graft here, probably I would have took Gladius. And what I'll do with Gladius, first I try and advance Gladius.
Okay.
If it doesn't advance, then just knuckle the same wire and go up.
Yeah, because that is the safest one, right? So knuckle one forms in the vessel architecture, it moves up.
Yeah. But the important thing is here, first you have to differentiate whether you are in SVG or RCA. Now we will realize, and
okay.
Now you can see both are in different directions.
But still different.
Now you can see, your RCA is dancing, separately from your retrograde wire.
But it's not anterior, it's posterior, the wire.
Yeah. Basically here the graft is laid, I think kind of it just went into posterior.
Posterior, yeah.
It all depends on, how surgeon finally lays the graft in relation to AV groove. Sometimes,
but still it is very difficult to say. I'm sure, of course, in this the RCA was coming straight and the retrograde wire is more posterior. But you may also sometimes feel that it's just subintimal and there is a large subintimal space, but it is they're in different planes. But if there is a SVG there, then I think it is difficult, as you say.
Yeah, most of the time, if you see that if CT scans and RC and SVG almost very close, Sharath said, till you come to that proximal AV groove, then you can't see the separation at all. Almost very close.
Just record this.
It's a very nice teaching point in this case.
Now you can see Himanshu,
very posterior.
The retrograde wire is just going in a different direction altogether. And you can see your antegrade catheter where it is.
Yeah.
Okay.
It has to, yeah. So now it is going, and it has to be imagined because this segment of the RCA is not filling from anti or retrograde, so we
Yes.
cannot see this segment.
Yes. And I just tried and knuckle just to see, advance further and see. But it is clearly not in a different track altogether. So we understood it is not in, in mid RCA.
What I can do is now I can even start anti-grade wiring and overlap wires.
But do you
So
this wire went into the venous graft?
Yeah. So
RCA.
At the anastomosis, of course.
Yes. From the anastomosis itself.
Okay.
But we don't know where the anastomosis is, right? Because we could never see that.
I saw it in CT. It is before the cuts.
Give me Gladius.
But see, again, Himanshu, in all the cases where I went retrograde with an SVG in distal RCA, so your retrograde wire preferably goes into graft.
Since retrograde wire is not progressing,
it goes into graft. Because what
Mm.
happens is,
don't have a
especially
great,
when the graft
what
is
to-
little
what to work with.
shorter than the
What I'll
graft is little shorter than what it is supposed to be, then it buckles your native vessel. And that when native vessel buckles, your distal native vessel will be coaxial to the graft. I mean, that is how surgeon
Exactly. It
lays.
forms a kink, right? It forms a kink like a
Yeah.
So
And
it always directs to the graft rather than
graft.
the proximal
So,
vessel.
see, in 3 cases of mine, your wire just went into SVC. And it becomes very tough to bring your retrograde wire into RCA, that is mid RCA, because it is also buckled there. And you really don't know because it is submerged in your CTO segment, and you don't know where you have to really turn your wire or direct your wire. And now you can see, yeah. So, but despite repeated attempts, but this, I couldn't able to bring it. Now you can see the retrograde microcatheter, and you can see this is antegrade wire.
Anchor. And we see very nice teaching. You see there is JR. So to increase support, he's trapping the microcatheter with a balloon to increase support for his antegrade wiring.
So this is anchor, and I took a antegrade Gladius, and I'm advancing. Now you can clearly see the catheter, the wires, and the distance between the wires.
Now you clearly see that from distal RC it has gone up. It is nice to see now. Now where it just exactly kinks, that is where it entered into the graft.
But your antegrade wire is it is Gladius?
Yeah, it's Gladius. You can see that short radio pack.
You can see
it is subintimal, but it is gone quite far.
Yeah, record.
I mean, we don't know exactly subintimal. I can only say it is within the vessel architecture.
Yeah.
But you can clearly see your retrograde microcatheter is in a different plane altogether.
Record. Now just go to left caudal to left cranial.
So at this point of time, you must have already made up your mind that this is going to be a investment procedure, right?
Yes.
Graph, there is bend formed in the native vessel. And
now you can see what we were talking about, buckling of vessel.
Yeah, exactly. You can see that buckling exactly there.
At 5 o'clock.
And the second important thing is you don't have to use contrast at all, right?
Okay. Back. Hello, please.
It's 2,700 milligray.
Yes. And at this stage, what I did, I pulled my microcatheter down. So you can see retrograde microcatheter, I'm coming down.
And for the audience, it's very important. On the screen, you say that K and you see 2733 written on in white, right? Everything else is in black. That is your radiation. So it is very important that we should have our eye there also. I mean, it is also radiation which is getting to the patient. So
yeah,
or both, yeah.
So now you can see we pulled a retrograde microcatheter which was in SVZ to the crux. So now I'm trying and sending retrograde wire using antigrade wire as a marker.
But why are you not advancing your antigrade microcatheter? It is still you're still trapping it with the balloon, but you could can you advance it and still the balloon will work, right?
Yeah, we can advance. See,
it's not yet sure that you are in the true lumen distally, so it is.
Yeah,
is that the case?
Yeah. See, we don't know. I mean, this wire is not in true lumen. So,
yes.
Second, my plan is to see here. Here, basically, I mean, somebody is talking in the background, so tell them. So here, basically, there is a bifurcation. CTO is extending up to bifurcation. So primarily, the safest strategy, if you want to save all the branches, is externalization, because that saves all the branches rather than conflicting with antigrade wiring.
Yeah.
So,
but Sharath, I'm just asking for everybody's sake. So, suppose we've decided upon investment procedure, and now for investment procedure, we know that our antigrade wire will be subintimal. We'll dilate the subintima and hope that it connects with the intima. Now, what is the risk of advancing the microcatheter? Anyways, we are going to balloon that segment of the vessel.
We can advance. We can advance. In fact, I have done it subsequently.
And Sharath, so far you have not thought about investment procedure, right? So
no, till now during procedure, I never thought of investment.
Okay.
That's why he's still advanced.
It's going to come. Okay. Yeah, then it is fine. Yeah.
Once he was very
otherwise, then if he's sure it's going to be investment, I'm sure he'll just advance the microcatheter and make space for the balloon, and then
go to retrograde microcatheter.
So here my plan was to get my retrograde wire. Tell Kiran or somebody, there is some background noise.
Sharath, so is there any sign or anything you can just to suggest that you are not in the true lumen with your antigrade wire?
Yes, the wire was not going freely from there.
Okay. Yeah, exactly. Okay.
Yeah. So wire was not going freely. So, and I don't want to give, injection, but even if you give injection, it is a bit tough to understand, where the wire is at that point. In fact, here I tried sending antigrade wire into retrograde microcatheter.
But it looks very close, right? So do you do little rotation to see that both are in the same plane? So always, is that practice here?
Yes, that's what we do in orthogonal views. We try to do it.
Because whatever we could see, but look like both in the same.
Yeah.
So that is the difficulty with this case. Like, it is a very long CTO. And to control the torque of the wire so far away from the microcatheter with so much disease is very difficult. And at the same time, you're not sure whether the wire is in the true lumen, so you don't want to advance your microcatheter also. And that is why antigrade techniques fail in these long CTOs, because the options are very less.
So now you can see we are injecting. So as you suggested, Vijay, I don't want to give full injections from left system.
The retrograde has come from a small branch.
And now you see that graft is filling now, right? It is.
Yeah, what is filling is graft from retrograde. It's not the native vessel.
Exactly.
And you can see that is quite straight to your distal vessel, then the vessel there. And you can as well see the vessel is the wire is taking a loop just before the crux. The antigrade wire is taking a loop. That is because of the graft pulling your native vessel towards its course. You can even appreciate here. That complicates, the moment I understood this part. Then I think mostly I thought of trying for some time, but I realized I have to take investment in this case, keeping that radiation in mind, and not much of contrast. We have not given much contrast here. So, but radiation and mic fatigue, team fatigue.
And another important thing is because you're done on graft-plasty, the patient is very stable, right?
Yes.
Despite having 2 gears.
Yes.
Antigrade and retrograde it is.
So you can see I'm repeatedly trying and using antigrade for retrograde wiring and retrograde wire for antigrade wiring. But you can see that retrograde wire is repeatedly going into graft. It's not coming into the RCA.
I think the retrograde wire, do you think it has come from the PD or it has come from a small branch in the PL?
That branch is exactly joining close to the crux. It's not into the PDA. It's coming, almost close to the crux.
Okay.
But see, whether you come from PDA or close to the crux, the retrograde wire preferably grows into the graft. Because over a period of time, your distal vessel, see, if you talk to surgeon, what surgeon says is, he will make sure that his graft is coaxial with the distal vessel. That is how they anastomose, to give a full flow into the distal vessel. And it naturally becomes coaxial with the distal vessel. And if you remember, we have mentioned all this stuff in our RCA CTO report. Not you. All the points are there. So, yeah, I think I tried a lot, bringing retrograde wire into antigrade wire direction, but it didn't work out. Then I tried sending antigrade wire into retrograde microcatheter, using microcatheter as a marker. So that also really didn't work out. So, and now I'm doing, you can see I'm advancing.
microcatheter.
See, the reason why microcatheter is going so easily across that CTO segment is I knuckled that entire area. We did a knuckling. So that is the reason it is going. And this is where the support is crucial. But once you knuckle, see what happens is you create a big space and usually your microcatheter goes. That's never been a problem. You can see that is just advancing. So we advanced microcatheter. And here, so I removed that wire because the wire is gladius. So I thought of taking a more directable wire, that is Gaia. So, and we took a Gaia now because that gives me a better directability. And while injecting retrograde, I'm trying to direct Gaia into the lumen, but you can see it is just going subintimally.
Because now the subintimal space is quite big.
Yes. So I think we tried a lot, basically in different views to penetrate into the vessel, but I think that the loop which is created by distal graft anastomosis actually is creating a problem. So I think at this juncture, so we decided, you can see already it is 3,700.
Yeah, I'm just looking there only.
So, and so.
Did you ever consider to go through another septal? Just for discussion's sake, did you ever consider that this is going into the graft and I should take another septal and see if it changes the lie or connection somehow goes to the RCA instead of the graft? Because you crossed so easily, no?
Yeah, so that's a good thought, but see, I told you, right, by this time, I already decided even before this time, I already decided I have to switch to investment for this guy. Because you can see now, so there is a huge subintimal space created.
Just explain what you are doing. From where are you injecting?
I'm injecting from retrograde.
Yeah, give me why.
Retrograde.
No.
Retrograde.
Yes, yeah.
Because the retrograde microcatheter is just beyond the crux, right?
Yes, yes, yes. Just at the crux.
So are you worried that this hematoma, you will be losing one of the branches?
No, and if I continue procedure, I will lose. But I already told you, right? By now, I decided to go ahead with investment. So you can see how, I'm handling my antegrade wire. So if I want to continue with the procedure, I won't handle my antegrade wire like that. I'm in fact knuckling there. So, and then, yes, we did the investment. Where is it? Yeah, I think.
Yes, in plate.
So you can see I'm just dilating with the, you can see this is a balloon.
Yeah,
I brought a 2 millimeter balloon. So I'm, my, generally what I do is I dilate beyond the distal cap. So you have to create a space up to beyond the distal cap. So then, there is a possibility, some microchannels or fenestrations can form, and then, you might get a easy entry in future.
Yeah, let's. Okay.
So we dilated the entire RCA. So, right, I think, and now comes, I pulled, so my retrograde back. And now comes the question. See, even after investment, say, your success of antegrade in next sitting will be like around 50 to 60%. And you might need to still go retrograde in next sitting. We are not sure about it. So, and that is, see, do I need to stunt this LAD or not? Because if I have to make my next procedure straightforward, so LAD should be patent for me. So what do you guys think? What are your thoughts there? But I think obviously Himanshu will be unhappy with my decision.
No, sorry, Sharath. I actually got another call from the hospital, so I just missed for 2 minutes. But I'm so sorry. I'll not disturb you. Please continue.
We dilated talking about stenting the proximal LAD, Himanshu. So because it's funded up. And Sharath, did you IVUS it? So just how difficult, how bad is the vessel? So if you feel you get very good results, I think you should do it because you've opened it.
LAD?
Yeah.
Yeah, we did IVUS. Yeah, but here the point
bad was the proximal vessel?
Yeah.
The heavily calcified are this thing, so that is the CABG vessel, right? It is.
Yes. We did IVUS, Vijay. But the point here is, so investment. See, investment for next procedure is the key. It's not just a subintimal dilatation of CTO. So I would see this investment as a comprehensive entity, not as a single entity. So in this case, yes, I created a subintimal space all across the CTO segment up to the crux in RCA. But I also need my first 1.5 hour, that is nearly 1800 or 1600 gray radiation is gone for, LED wiring. So I don't want to end up in the same situation in my next sitting. So that is the reason I decided to just stunt LAD, because this acts as a full investment for me for my next procedure. Yes, if there is a good antegrade microchannel in the next sitting, I think it will be done antegradely. But if I have to take a retrograde, my retrograde route is also like highway next time.
So Dr. Sharath, in this, so for the audience, now you see the distal right, you see a large hematoma there, the contrast staining there, right? So at this point, till what segment of the right coronary artery do you want to do this investment, you don't want to do the investment beyond the crux, right? Because then you may have a dissection flap in front of one of the branches. I mean, I don't know if it is a problem because it is filling retrogradely anyways from the LAD.
Yeah.
But can you explain how to do investment when there is a bifurcation involved?
Yeah. So Himanshu, so in this case, if you understand, PDA is filling predominantly from LAD, PLVP is filling predominantly from LCX. Okay. So once, okay. Sorry. Okay. So predominantly from LCX. So even if you do, see, and investment typically we have to do beyond the distal cap. We have to dilate beyond the distal cap. Okay. So in this case, obviously, I dilated into PL, maybe, 5 to 10 mm into PL. So I dilated that entire segment in a subintimal zone. And there is no need to worry about what happens to PL because what happens to PDA, because the flow from into PDA is from LAD and flow from PL is from LCX. So there is no, your PD, if PLVB is dependent on your PDA or PDA dependent on PLVB, then we are going to create some problem. But when both are filling from different sources, there is no need to worry. You dilate beyond the distal cap, and that is most important. Dilating beyond the distal cap is most important. See what exactly happens when you dilate beyond the distal cap. In your dilatation, you are going to create some fenestrations in your flap beyond the distal cap, and those fenestrations will become a microchannel in your next sitting, which flows through your subintimal zone. So in next sitting, your procedure may become a simple antegrade. If you dilate only into the middle of the CTO, that is not a full investment in such cases. So only advantage you have is, you have some more CTO segment kept open for your next procedure. So I would prefer to dilate beyond the distal cap into the PL.
So can it happen when you do an investment procedure across a bifurcation in a RCA or say a major diagonal? You come back the next time, it becomes a simple antegrade for one of the branches.
It is possible, yes, for one of the branch, but for other branch, yes, you can use some WMN catheter or something, and you can re-enter. In this case, it's PDA is endangered. So PL, because we are dilating into PLVB, if one of the branch is patent, that will be usually PLVB.
The PLVB,
and that PDA, so you have to, that is the reason, you have to keep your PDA route as an highway. If that LAD gets occluded again, then it becomes a problem.
So these are very important points for audience and everybody to learn, that if you have to do investment across a bifurcation, try to do investment into the branch that you think is more important or bigger. Of course, the second will be collateralized, but at least if you have to save one with a stent, try to save the bigger one. But this picture is very scary that you are taking. No, Dr. Vijay, we see the whole right crux with a large hematoma.
Yeah, it looks.
But no need to worry, your PDA is filling and PLVB is filling from the other collaterals.
Yeah.
So where from I am injecting is a septal which is connected at the crux.
Yeah.
And the reason why we are not able to see entire PDA PLVB is because they are filling nicely from the collaterals. So yes, I mean, this is where I decided, I'll go ahead and stunt, this is LAD. I was
back. Yeah.
As you asked, Vijay, this is LAD.
Yeah. It doesn't appear to be a bad vessel, right? It is not much of calcium so far, whatever you could see.
Yeah. So I think length and, this is a stunt I took, I deployed.
From the left main.
Yes. And this is post dilatations I'm doing. And that is a part we did. And
check.
I think I'll show you
Sometimes CTO also should have two teams. Like in sometimes very complex calcified lesions, you need two teams, one to do post dilatation and one to do up to post dilatation, because it is you are tired. Sometimes you're really tired by that.
Yeah. I think yeah, now we'll show the final result.
One side
This is all I was.
pressing Austin, other side is free. I mean, then only you can re-engage your guide next procedure. Okay, come, epicaudal. Don't move the table, please.
Yeah, this looks very good.
RCA is feeling nice. You want to give one epicranial, just give one epicranial.
Now you can see RCA flow, Himanshu.
Yeah, it looks very nice.
RCA septal syringe, please. RCA.
And we can't, we are not able to see up to the cracks. That could be, partly because of hematoma, and that could be partly because there is some flow from antegrade, with some, fenestration. We're not sure about it.
And now you have a lot of competitive flow in the diagonal also.
Yes.
Okay, done.
And your RCA is much, your collateralization and collateral flow into RCA is much better than before, as after we opened LAD.
Yeah.
All right, why did no?
But I think I also generally I also
Is there something left in the LAD?
What we did is
nothing.
There is something known as investment procedure. We open entire RCA. Now the connection should form. Okay. Next time it should be done only in an antegrade fashion. So see, what is most important is time. We can't. But you want to do some here? Fine.
Because it's important for the audience also, since we are here. See, it is almost 5,000 milligram. Now you are protected with lead and everything. The patient is not. The patient is lying on the table, and generally you are working in just maximum one view. So he may have one area of his back or buttocks or shoulder which is getting a lot of radiation. So sometimes these patients, in future, they may have a problem. So our responsibility of radiation is not just to ourselves, but to the patient also who is on the table.
So left is completely open now. So you'll have good collateralization to right only. Next time also, anyway, we open left now.
So I think generally I always give a small injection, but never a forcible injection into right. You can see that's why I'm taking a 5 French catheter.
Managing time.
Just to understand, your subintimal space is open.
Let us see what happens.
Yeah. Yes.
Yeah, it will be interesting.
But it's a very slow injection, we don't give give a forcible injection, then, you can create a huge hydrodissection. You can see, that subintimal space is just flowing. So I'll just see that, that's all,
But what is the advantage of this injection, Sharath? We don't see anything beyond the mid RCA here, right?
No, I'm not injecting forcibly. Otherwise, you can see the contrast is going down. I've not taken a long cine. So
we created space in the vessel.
So there is a myth. So let us discuss, since we are discussing investment. So some people have a doubt that, if it is subintimal, if you give contrast, the contrast will not clear at all. So it will become like a JPEG image. So let's discuss if the whole vessel is dissected up to the apex, suppose, right? And we do investment procedure, you give contrast. Will the contrast stay in the subintimal space or it will clear out?
No, it generally won't clear off, and it generally, your entire subintimal space may not be delineated by contrast as well, because when there is no outflow from subintimal space, whatever contrast you are giving, it won't reach your entire subintimal space. You only see some proximal portion, and rest of the portion may not be visible. Like here, where
but will the contrast clear or not, Sharath? Will the contrast clear out or not clear out? Will it become like a no flow contrast injection, or it will clear out subsequently over few heartbeats?
After few heartbeats, yes, it may get cleared off. That is mostly a kind of dilutional effect. Or if you have some fenestration, see, many times what happens, even in a subintimal space, you dilated, or your wire is in subintimal space. Sometimes, you create some perforations into true lumen, right? We are not sure, where the perforation is, but when you are giving a contrast, that contrast can go into your true lumen through that small perforations which are there, or small connections which are there between false and true lumen. And that is the whole logic about investment procedure. If you have any such connections, those connections will sustain, and they become a track after some time.
So that is what I have also seen. If there is a large dissection, even if it is artificially created like a subintimal investment procedure, you give contrast, actually it clears, and then sometimes you would feel that no, maybe it is intimal because it is clearing, but it is not true. Sometimes subintimal micro connections are there and the contrast clear. So subintimal injections will not always be like no flow injections of a LAD or acute MI, that the contrast will just stay there. So they also clear out. Yeah.
Sometimes, see, that is a whole logic of Carlino's technique. Say, you are not able to bring your wire into true lumen. You just inject contrast. Right? Sometimes, your contrast itself may cause kind of hydrodissection and enter into true lumen distally. And then you just wire.
So,
that is the logic behind Carlino's technique. So, So I think with this live in box is over.
We had good discussion. So Dr. Vijay, any comments? We had good discussions around this case. Anything you would like to tell the younger colleagues about the safety of this procedure? What precautions should they take before they attempt this kind of procedure? Anything you would say, sir?
Yeah, and again, it is to be done by a well-experienced operator. That first message you had to take, and how elegantly he demonstrated that every time he ensured that he is in the vessel architecture. That is the most important message you had to take. How he careful. Just even this case nicely showed that how to differentiate between a graft and this thing. It was almost impossible till he reached AV groove. That was an amazing demonstration in this. And safety, every even each and every step, Sharath took all the care into not to compromise the safety of the procedure. That is the most important message you have to take home when you do such a complex procedure. It's an amazing demonstration, Sharath.